Hello, everyone. We've just opened up the webinar. We're going to give a couple of seconds here for people to filter in. You'll see a slide right now with some really basic housekeeping. Firstly, welcome. Secondly, letting you know that this webinar will be recorded. You'll notice that your microphone and your camera have been turned off, and they will be off for the duration of the webinar. But to ensure accessibility, live captions can be enabled from the control panel. If you navigate to the control panel, you can turn that on. All right, let's jump in. Hello, everybody, and welcome to our webinar, Moving Research into Practice, Innovative Knowledge Translation or KT Strategies in Outbreak Investigation Communication, Global Ecohealth, and HIV Prevention. My name is Robin Trainer. I'm a knowledge broker with the National Collaborating Center for Methods and Tools. More about that in a moment. And I'm joined by three presenters who I'll also introduce in a moment. One more slide of housekeeping. If you are experiencing any technical issues throughout today's webinar, please type any of your questions into the Q&A. My colleague Christiane Camargo is here, and she will be answering any of those tech issues and trying to help you along your way should you have any questions. We've disabled the chat for this webinar. We're asking that everybody post, again, their tech issues or any questions throughout the webinar, questions about the content into that Q&A window. It makes it easier for us to manage one window of questions rather than having questions kind of throughout. So please post your questions there, your tech issues and your content related questions in that Q&A section. And you'll see that when you open up the Q&A section, you have an option of upvoting certain questions. So if somebody has asked a question that you also have, you can, rather than retyping it in, you can vote for it, upvote it, and this will make that question move to the top. It prioritizes those more common questions. The other thing that we'll be doing throughout today's webinar is posting some polling questions. You'll see some at the beginning, you'll see some again at the end, and I'll alert you when you see those, and we encourage you to participate. After today's webinar, the slides and a recording of the webinar will be available in about 2 weeks. We typically announce when it's available on our LinkedIn. You can find the recording on our YouTube channel linked here. And if you'd like access to the slides, please send us an email at nccmt@mcmaster.ca, and we'll be happy to send that content on to you. This is our standard disclosure side. The NCCMT is funded by the Public Health Agency of Canada. We're affiliated with McMaster. The production of this presentation has been made possible through a financial contribution from the Public Health Agency of Canada, but the views expressed here do not necessarily reflect the views of the Public Health Agency of Canada. And as I said, NCCMT is affiliated with McMaster University. That's where we're located. And McMaster University recognizes and acknowledges that it is located on the traditional territories of the Mississauga and Haudenosaunee Nations and within the lands protected by the Dish with One Spoon Wampum Agreement. So what are we going to do today? Today, we're going to start with a really brief introduction to the National Collaborating Centers. Many of you on the webinar today are probably familiar with us already, but we'll just start with a really brief overview of who we are and what we do. And then we have 3 exceptional student presentations. I'll explain who these students are in a moment, and a really brief overview of what their presentations are all about. And then a Q&A session after the students provide their presentations, and then some links at the end to more resources if you want to, again, learn more about what we do at the NCCMT, and click on some more resources to continue your learning. So let's start with one of these webinars, one of these polls that I promised. So Krishen has just posted up on your screen some pre-webinar polling questions. So we're interested in whether or not you visited our site before, and if you have, how many times have you used our resources? This is helpful for us as we are planning additional outreach, as we're planning how to better promote our resources and how to maintain and improve our resources so that they are most effective for our target audience. So we'll give a few more seconds for people to finish that. And I'll give you a little behind the scenes here. It's kind of a 50-50 split for people having visited the NCCMT. So actually that's great. Then it means we've got some new audience members here today. And then if yes, how many times have folks used the resources? Some, many, many times. And again, about half, obviously, if you've never been to the website, you've never used the resources. Okay, great. Thank you for that information, everybody. Again, it's really helpful for us as we continue to plan. All right. So jumping in then. So at the National Collaborating Center for Methods and Tools, we are one of 6 national collaborating centers funded by the Public Health Agency of Canada, and we've been funded by them since 2007. Together, we work to strengthen and support public health, and each of our 6 centers has a different focus. We're located across the country, as you can see on this map, and the areas that we cover include Indigenous health, infectious diseases, determinants of health, healthy public policy, environmental health, and then ourselves, the methods and tools. One of our collective National Collaborating Center initiatives is to support and recognize the efforts of Canadian public health scholars. And we do this through our Knowledge Translation Graduate Student Awards. So these awards recognize graduate students and recent grads who are leading high quality, innovative, and impactful knowledge translation projects in public health. So again, the purpose of the awards is to recognize the work of graduate students regarding specifically knowledge translation in public health in Canada. So CIHR's definition, what's a webinar without a definition, right? So KT being this dynamic and iterative process that includes synthesis, dissemination, exchange, and ethically sound application of knowledge to improve the health of Canadians and provide more effective health services and products, and to strengthen the healthcare system. So again, this is a definition that comes from the Canadian Institutes of Health Research. The focus of this award then is on the individual student's role in a project. This year, we received 17 applications from master's, PhD students, and recent grads from all across the country. And these applications were reviewed by a subcommittee of National Collaborating Center staff. So again, staff from all of those 6 centers. And they were scored according to this criteria that you see on the screen. So relevance to knowledge translation in public health, creativity and innovation, this was shown in the project, the scholarliness of the project, the potential impact of the project, and the quality and the degree of support coming from the academic supervisor. The award winners received a certificate and a financial award to support their registration and attendance at the Canadian Public Health Association's annual conference. And this year it was in Winnipeg in April. So that's what the award is all about. That's what it focuses on. And what we have here today are the 3 winners of this year's award. So it is my pleasure to introduce the recipients of the 2025 National Collaborating Center for Public Health Knowledge Translation Student Award winners. We have all 3 joining us today. We have Vayshali Patel, who's a PhD candidate at the University of Guelph, and she's going to talk to us today about her project evaluating public understanding of public communication products during multi-jurisdictional enteric illness outbreaks. Then we have Angel Kennedy, a PhD candidate at Simon Fraser University, and she's going to present on her project, Bridging Global Communities Through Knowledge Translation, the Global Ecohealth Summit. And then finally, we have Fatima Zulfiqar, a Master of Public Health student at the University of Toronto, and she's going to present on her project, Translating HIV Prevention Guidelines into Practice, a knowledge translation approach to enhancing PrEP uptake among family physicians. Each of these 3 award winners will present their projects. They've got about 10-15 minutes to do so. And then we'll save time afterwards for somewhat of a panel style Q&A. So save your questions for after all 3 have spoken, and we'll have a nice Q&A chat once they've all given their presentations. So with that, I'm going to hand it over to Vayshali to talk about her presentation, to talk about her project. And you should now be able to control the screen.
Sorry about that. I was just looking for my unmute button.
Perfect.
Okay, so thanks for the introduction, Robin. And to reiterate, I'm Vayshali. I'm a PhD candidate at the University of Guelph, evaluating the public's comprehension of risk communications during multi-jurisdictional enteric illness outbreak investigations. So today I'll provide a brief introduction to the research project, and then I'll present the findings for my 2-phase research project and wrap up by discussing some implications of these findings. So before I begin, I'd like to acknowledge that I'm a settler on the treaty lands and traditional territory of the Mississaugas of the Credit, and I'm grateful for the opportunity to work on these lands and recognize the contributions of Indigenous communities, both past and present. Introduction to enteric illnesses. So individuals can become ill from the consumption of contaminated food or water through contact with animals, person-to-person contact, or contact with animals, depending on the pathogen. The group of illnesses primarily affects the gastrointestinal system and commonly manifests as nausea, vomiting, and diarrhea. Though most enteric illnesses are self-limiting, they can require hospitalization and result in death. While everyone is susceptible to enteric illnesses, some individuals are at greater risk of illness and adverse outcomes if they do become ill. Well-defined high-risk groups include young children, older adults, women who are pregnant, and those who are immunocompromised. However, other socio-demographics and environmental factors may increase risk as well. Enteric illnesses pose a public health concern. The global burden of foodborne diseases is similar to that of major infectious diseases, including HIV/AIDS, malaria, and tuberculosis when measured on a common scale. Oh, sorry, I don't know why it's sorry about that. And in Canada, there are approximately 4 million episodes of enteric illnesses, leading to over 11,500 hospitalizations and just over 200 deaths annually. Risk communication is a key public health intervention known to reduce enteric illnesses. According to the World Health Organization, risk communication can be defined as the real-time exchange of information to people affected by a hazard or threat to their health and well-being. Effective risk communication is important to raise awareness, enhance understanding, and motivate behavior change among Canadians during outbreaks. In Canada, an outbreak is multi-jurisdictional when ill persons reside in more than one province or territory and in Canada and another country. The Public Health Agency of Canada is a part of the federal health portfolio and responds to these outbreaks, which include communicating outbreak investigation details and health protective information to the public on behalf of the Government of Canada. Their risk communications include public health notices posted to the Government of Canada's website, which can be seen on the left, and corresponding social media messages on Facebook and X. As previously mentioned, this research can best be described in 2 phases. The first phase occurred from 2022 to 2024. In 2022, FACT conducted an internal investigation of its foodborne and waterborne enteric illness activities and recommended further review of its risk communications. In 2023, I conducted content analyses to examine FACT's existing communications. And in 2024, FACT updated their public health notice template based on best practices and research findings. And the next few slides will discuss each of these steps in more detail. So as mentioned, in 2022, FACT conducted an investigation of its foodborne and waterborne activities from 2017 to 2018 and 2021 to 2022 using document reviews, literature reviews, and key informant interviews. FACT's evaluation found that its communications generally aligned with international guidance for foodborne outbreaks, but its approach could be improved to make communications more comprehensible. Specifically, interviewees pointed to the United States Centers for Disease Control and Prevention's communications as a good example of comprehensible information. Ultimately, to ensure the continued success of its program, FACT recommended examining public communication activities to implement best practices that optimize accessibility, usefulness, and understanding of public health messaging. In 2023, I conducted content analyses of FACT's risk communications. Specifically, a part of my content analyses examined FACT's public health notices and social media posts using the Centers for Disease Control and Prevention's Clear Communication Index, a research tool intended to help develop and assess public communications. This research found that while public health notices generally align with the Centers for Disease Control and Prevention's Clear Communication Index, use of plain language and clear communication of risk and numerical information could be improved to enhance the public's understanding. And in 2024, in collaboration with FACT, a new public health notice template was developed and informed by content analysis findings. FACT updated their public health notice template, including the use of clear language principles while ensuring numerical and risk information was more clearly presented. Specifically, an epidemiological curve was accompanied by a plain language description to help individuals better understand the numerical information. Additionally, relevant risk-informing information was moved from the bottom of the PHN to the top of it. These changes also aligned with the recommendations from FACT's own internal investigation from 2022. Limitations of the aforementioned content analyses included using the Centers for Disease Control and Prevention's Clear Communication Index to assess the public's potential understanding. However, it didn't exactly assess their direct understanding. To fill this gap, a survey and focus groups with the public were conducted from 2024 to 2025, marking the completion of this 3-year-long research project. Next steps include preparing a presentation and report of research findings for FACT. And the next couple of slides will discuss each of these steps in more detail. A nationwide cross-sectional survey was conducted in 2024 to explore the public's awareness, understanding, and use of FACT's risk communication products, capturing approximately 2,300 responses. Focus groups with the same pool of participants were used to gather richer contextual data that may have been missed from the survey. Ultimately, the key findings were as follows. First, awareness of FACT's risk communications was low and could be improved using a multi-channel integrated approach, consisting of both pre-existing channels and new preferred channels. Second, Canadians generally reported a full understanding of communications. However, focus groups found knowledge gaps, specifically when communicating risk and numerical information. The participants would use this information to falsely lower their risk perception, which can harm public health messaging. Third, while survey findings indicated that most participants would use FACT's communications in the future to inform behavior changes, focus group participants were hesitant to perform behavior changes due to a low risk perception and cited perceived barriers, mostly surrounding financial constraints. So what's next? A presentation and report of all research findings will be prepared to help inform changes to risk communications and include the following recommendations. First, implement a multi-channel approach using a variety of sources. Second, enhance understanding by incorporating best practices for clarity, for example, the use of the Centers for Disease Control and Prevention's Clear Communication Index. And third, use health behavior change theoretical frameworks such as the health belief model to develop risk communications that can help motivate behavior change. The results of these research findings can be used to enhance FACT's current outbreak communications by raising awareness, enhancing understanding, and motivating behavior change. Further, these research findings can also be used to enhance communications during other communicable disease outbreaks. Thank you.
Great. Thank you so much, Vayshali. So like I said, keep your questions for her for after our other two speakers speak. But next I'll hand it over to Angel.
Thank you. Does it look like I can do the slides, Robin?
Yeah, you might have to request control. Is there? There it is. All right, try now. Perfect.
Hi, everyone. I'm so grateful to have received this award and to be in the space with you all. So as Robin said, my name is Angel Kennedy. I'm a PhD candidate at Simon Fraser University, and I'll be presenting today on bridging global communities through knowledge translation, the Global Ecohealth Summit. And I just want to begin by acknowledging that the work I do and the ways that I've come to understand it are really deeply rooted in relationships with place and people. I live, work, and learn on the unceded, stolen, and never surrendered lands of the Coast Salish peoples, specifically the shared traditional territories of the Musqueam, Squamish, Tsleil-Waututh, and Coquitlam nations in what is now called British Columbia, Canada. And I also want to acknowledge the lands and stewards of the lands on which the Earth Hug takes place around the world, and the many Indigenous nations, knowledge keepers, and communities whose expertise in planetary well-being has existed since time immemorial, and well before it was colonially coined planetary health. So I like moving my acknowledgements also to commitments. And so as I speak about knowledge translation in planetary health, I hold myself accountable to challenging colonial and extractive approaches to planetary health and education and decentering Western individualistic frameworks in KT. I also wanted to take a second to honor the various places in which this work has emerged and been strengthened. I was a trainee back when I started my master's in public health for the Environment Community Health Observatory Network, which was led by Margot Parks. And thanks to Margot, her and I had the initial idea for Earth Hug, and Margot kind of encouraged, she always encourages you to do the big ideas that you have. So I'm really grateful to Margot as well for that. And through that work with ECHO, we planned and co-hosted several events, including one with Stilleton First Nation and the one shown here with Cowichan tribes on coming together as a whole, connecting health, communities, lands, water, and climate. And during this event, we brought a bunch of youth from northern BC down to Cowichan, which is on Vancouver Island in BC. And this was an intentional space to have place-based conversations with a group of decision makers and practitioners, community leaders, youth, and researchers. And it was here in that circle at the bottom right, actually, that I really tangibly saw the depth of conversations that can happen when people with varied lived experiences and roles come together and all get space to share about a topic. And so conversations in that meeting actually bridged to action because policy folks wrote briefs of our conversations after, and decision makers who were in the rooms really worked to implement it. So that was a really key moment for Earth Hug. And then later on, I helped Maya Gisselson design and run an undergraduate and graduate level field course on Cortez Island, which was this intentional effort to bring eco-social approaches into the health sciences curriculum at SFU and bridge global health principles with local realities. And so seeing the impact that that experience had on students solidified for me the value of moving between global and local contexts for knowledge translation, which also fed into the project that is the theme of this presentation. So for the past 4 years, I've designed and been running alongside a small team a global event focused on knowledge sharing, transdisciplinary learning, relationship building, and fostering global support for local action. In these events, we come together as a global community for 24 hours of dialogue over Zoom, which take turns kind of being hosted in different regions. So usually we have North America, Turtle Island, Asia, Middle East, Europe, Oceania, Africa, and South America, or Abya Yala. And in this way, we work on having regionally relevant discussions that link back to larger global dialogues on the central theme of working together for a healthy, just, and sustainable future. And while this theme has been consistent across all the sessions and all of the years, it is up to the regions to focus on what feels most relevant and notable for their regions at the time within that topic. We've also been really intentional to try to ground the events in an ethic of care and love for ourselves, for our more than human relations, each other, and our planetary community. And we've done this by moving away from presentation formats where possible to foreground personal connections and storytelling and sharing challenges and victories with each other. So it can be a space where we hold things for each other and with each other and also celebrate the things that are working. And sometimes regions do choose to do presentation format, which is okay, but many are loosely moderated conversations and connection points, which is also why I often call the Ecohealth Summits, and many people do the Earth Hug. And so I'll refer to it as Earth Hug because that's where it kind of started. And so participants at Earth Hug regularly say that this kind of approach leads them to feeling less alone in their work. And then, a core goal of these Earth Hugs is knowledge translation for planetary health, One Health, and Ecohealth between various kinds of knowledge holders, including government decision makers, researchers, Indigenous elders, youth, artists, activists, community members, and really anyone in the global community interested in this theme of working together for a healthy, just, and sustainable future. And we try to be intentional about taking an equity-oriented KT approach and enhancing accessibility to different sessions. So we often encourage multilingualism in the sessions with live translations. And I'm not sure if Carlos Sanchez-Pimienta is in the room, but he is always pivotal in helping with the South and Latin America session. And so in that one, it's always Spanish with Portuguese and English translations. So thanks, Carlos. And we also try to make modifications to each year based on feedback from previous years. So this most recent iteration included workshops after each of the regional dialogue sessions to help participants integrate the conversations into their different areas of practice. And then also in the first year, it was 24 hours continuously, but after feedback and also having a hard time for our team staying awake, and now it's a multi-day event that still spans 24 hours of conversation. And we use various platforms in sharing during and after the events. For example, we use a Padlet, which is shown here. I think this is the one from the first year. We use this Padlet so participants around the world can share their stories and links, poems, really anything that they find relevant for themselves working together for a healthy, just, and sustainable future. And this is a way for them to see examples from around the world outside of just the speaker's stories during the events, which we implement to try to reduce like hierarchies and knowledge and just being a passive participant in the sessions. It also makes all the regions accessible to participants, even if they can't join that session. And then we post our recordings of each session on our YouTube, which the videos have been used in classrooms around the world, we've heard, which is an exciting kind of ripple from this work. And after the events, we also create a polar steps as a summary of the event, where registrants can see where the speakers were sharing from, what they shared, and how we kind of move together around the world with geolocated points. And then we also encourage whole human and region sharing. So we encourage the sharing of regional music at the beginning of every session and have in the past created playlists for participants after the event as a way to bring music into conversation as well. And so as I was saying, something that's been really interesting is how the theme has stayed consistent across all the years, but each year we really have such diverse conversations coming up. And we find that sometimes these variations align with global political circumstances or planetary events, or really what communities are thinking about at the time. So in the first iteration of this event, key discussions were really around like climate change and Indigenous knowledge, sustainable development, mental health, antimicrobial resistance, and gender and social equity. And kind of the motto that emerged naturally was thinking globally while acting locally. and promoting intergenerational justice. And then in the second year, there was a really strong advocacy for adopting a holistic and transdisciplinary approach to emphasizing the interconnectedness of human, animal, and environmental well-being. Community engagement was a really big conversation around actively involving communities as contributors in policy, creative endeavors, and sustainable initiatives. And the really interesting kind of new point that emerged that year was the potency of art and communication, particularly performance drama, being recognized for conveying complex ecological messages and raising awareness about these topics globally. And the sessions also stressed ethical considerations and a departure from Eurocentric models. And then we heard after this event that several of the community members and government personnel that met during the event formed some partnerships after they joined. And then the most recent one that just happened in March, this one was our biggest one yet. It connected over 700 people from over 140 countries. And a really powerful message this year was that planetary health requires a holistic and interconnected approach, emphasizing that healing the earth means healing ourselves, remembering our sacredness and responsibility to each other, and really integrating ecological, spiritual, and cultural wisdom together in approaches around the world. The discussions explored systems thinking as a transformative worldview that fosters self-awareness and relational change, and fostering collective imagination. And ultimately, these sessions underscored that building a healthier, more sustainable future really requires more than just technical tools, but deep relational work and collective transformation. And then each region hosted a workshop, which included healing and heritage, equity-oriented climate planning, systems thinking and science communication, gender and social equity and policy, land body mapping, fuzzy cognitive mapping, and building resilience against spillovers. So I've done a lot of courses on like integrative KT and equity-informed KT, and applications of health in KT, and I love KT, but running the Earth Hug, I've really learned so much about what kinds of communication, human-to-human connections really build the relationships and kind of inspiration that can carry the changes that are really hard but important to achieve right now. One participant in our last event said that connection is a form of resistance, which really speaks to how connection through KT, I think, can also really make a big difference. And it's been really hope-inspiring to hear about how being connected to a larger community of support or KT can keep people in this work, especially amidst the hopelessness associated with like global political, environmental, and social events going on in the world. So I also just want to recognize the amazing early career people from around the world who have over the years made these events possible. It's grown over time. So just appreciation to Carlos, Evan, Christina, JP, China, Chester, and Halase. And I'll leave my information here. If you want to be in touch or would like a summary or more information or anything, please reach out. Thank you.
Great. Thank you so much for that, Angel. All right. So now we have our final award winner, Fatima. And Fatima, if you want to, oh, you're on it. I will give you control of the slides.
Thank you.
I will mute myself and it's all yours.
Lovely. Okay, there we go. Okay, I'm oriented. So, hi everyone. My name is Fatima, and I'm a Master's of Public Health student specializing in epidemiology at University of Toronto Dahlana School of Public Health. And today I'm going to be talking you through a cool little tool that my team and I built in order to disseminate the new HIV guidelines among family physicians here in Ontario. And so before we start, as of course, I'm going to go through the land acknowledgement. And so the University of Toronto is situated and operates and has been operating on the traditional land of the Huron, Wendat, the Seneca, and the Mississaugas of the Credit. And today I want to acknowledge the fact that I get to, again, like Angel said, learn, grow, and play on this land, and I am so incredibly grateful. And so I will start with team introductions. So our team is small and it's mighty, but here is everyone on our team. So this project actually stemmed from a course, actually, and the course is led by, on the left-hand side, you'll see Dr. Francisco Ibanez Casaro, and he is a very prominent advocate for HIV prevention, screening, and treatment outcomes. And so this course is led by him, and the teaching assistant or the PhD candidate who is supervising us through the majority of it is CN. And then we actually had the opportunity to collaborate through this course with the Ontario HIV Treatment Network. And so our point of contact there was Diana Campbell, who is the senior lead education lead. And then, of course, we have my peers and I, so myself, and we have Shayam and Gabriella, who were also fellow members of this course. And we made up a little team, and we basically had the instruction from the Ontario HIV Treatment Network that, hey, we've updated some HIV guidelines and we want to find a way to disseminate them among family physicians who are already overworked and a little burnt out, and we want them to be able to use them effectively. So that is our team. And so before we begin, I again want to emphasize the public health importance of PrEP and what HIV can mean if left untreated. So PrEP, in a sense, is for HIV prevention and is for individuals that are HIV negative. It's not a treatment method. It's not an antiretroviral that can be used as medication, but rather it's for prevention. And so if we get into the nitty-gritty a little bit, it combines two antiretroviral drugs and it prevents HIV in HIV negative people. And so how it works is that it prevents HIV or human immunodeficiency virus from taking hold of the body and spreading. The people who can take it have to be HIV negative, and they have to have some sort of a risk of exposure, whether that's through sexual intercourse or whether that's from injection of drug use. And how it's taken is that it's traditionally available in two different forms. So one is a pill, which is taken daily, and the other option is an injection, which can be given every 2 months or so. And the considerations here is that PrEP is not a catch-all, and so it's not going to protect individuals from other STDs. And so we want to destigmatize that a little bit, that PrEP is not a catch-all, and so even if you are taking PrEP, you still need to be taking the protective measures to prevent yourself from contracting STDs. And so the wonderful thing about PrEP is that it can actually reduce the risk of contracting sexually transmitted HIV by 99%. And so if that doesn't emphasize it, PrEP is very, very crucial and important in preventing HIV transmission. And so to give you a little bit of client background on who the Ontario HIV Treatment Network is, they're a nonprofit and they're funded by the HIV and hepatitis C programs at the Ontario Ministry of Health. And they are this wonderful node of collaboration, and their work brings together all of these different partners from across the HIV prevention sector. And what their mission is that they want to improve the health and the lives of people living with and at risk of HIV by using data and evidence to drive change. And so just going to pull a direct quote from them, as I mentioned, their mission statement is listed there, and they are, again, a node of collaboration between the testing programs and clinics, as well as AIDS services and other community-based organizations. And they even also pull in the policy and system leaders. And so they are really trying to translate knowledge, evidence into policy that helps and protects lives. So here, I wanted to emphasize the point of contact that we have with the Ontario HIV Treatment Network, and then again, once again, why it's so important that we do this. And so to understand the importance of the deliverable that I'll be sharing in a few slides, as I previously mentioned, our goal was to help Ontario HIV Treatment Network achieve their goal. And so presently, there are over 30,000 Ontarians living with HIV today, and this number is likely underestimated. The reason being is because presently, with the UN AIDS goals, we want to essentially achieve 90-90-90 goals. And so for people who are unfamiliar with what that means, we want 90% of people to know their HIV status. Of those people who know their HIV status, we want 90% of them to be on retrovirals, antiretrovirals, and we want 90% of them to have a suppressed viral load. And so although Canada has made great strides in achieving these goals, we're still a little far off in the first two 90s, which means that some people are not even aware of their HIV status, and if they are, they aren't seeking treatment through antiretrovirals. And so we want to focus on vulnerable populations with the translation of these guidelines. And when I say vulnerable, that's notably Indigenous populations, African populations, Caribbean populations, and a population that went overlooked for a long time was women with HIV. Actually, living with HIV weren't fully considered at the beginning. And so the healthcare gap here is now we have guidelines. We want to get people to have and use PrEP, but the middle ground here is family physicians. So how do we get family physicians and empower them in a way where they feel comfortable assessing risk and prescribing PrEP? And so we had several conversations with Diana, who works and is obviously the education lead, and she was instrumental in providing us with a lot of feedback on how we could make things easily understandable, easily digestible. And so shout out to her for all of her help. And so these are the guidelines. And I put this up here, I'm not going to go through all of them, but this was just to give you a glimpse of how in-depth a lot of these guidelines are. But the broad four categories is they want to emphasize who PrEP should be recommended to, who should it be prescribed to, what are the different prevention options. Sometimes people are deterred from taking PrEP because a daily pill sounds too much to keep up with, but we want to emphasize that there are so many different avenues that people can take. It can be dosing, injectables, something that's a little bit less demanding of you. And then there's also HIV treatment recommendations. If someone is at high risk, how often do we want them coming in to get tested to ensure that they either know their HIV status or they're subsequently prescribed PrEP? And so, again, to bring it back, the target audience for this deliverable was the family physicians across Ontario, and we wanted to make guideline dissemination more accessible. So we were given a style guide. It might sound a little bit obvious, but sometimes we don't realize the power that colors and color schemes have on uptake of information. So we wanted to show and present something that didn't come off as harsh. So we want to stay away from reds and a little bit more harsh colors of that nature. So we went with more of a teal, a welcoming, a soothing, a calming style guide. So here's our style guide here for your reference. And now I get to present the final deliverable to you here. So here it is. It's just a one-sided, dual-sided paper and handout, and it's just meant to basically as concisely convey all of these guidelines. So as you can see, on one side, we have a more detailed version with QR codes that will lead family physicians, should they want more information, to the actual guidelines, because we don't want to leave everything bare bones. If you want more information, it should be presented to you. And on the back end, we have a flow chart, and this is to assist family physicians in assessing risk, then subsequently, okay, I know the risk of this individual, they're high risk, they fall under this category. I think this option of PrEP would be best suited for them. And so the dissemination for this was in-person distribution. So Ontario HIV Treatment Network has several conferences that they attend that are HIV oriented. And so these would be handed out both in person, and also there's a large mailing list of family physicians who are in contact with the OHTN. So those also would be sent out. And here's just some potential conferences that we're looking towards disseminating these at. And then this is just a bit of a closer look, some of the considerations that sometimes get overlooked, but we wanted to highlight here. So we wanted bolding to catch the attention. And we also wanted, like I said, the QR codes for assessing treatment should people want more information. We wanted things to be easy to follow. We wanted colors that were contrasted well and had a high contrast. And we wanted to bold and highlight key points. So for example, here you'll see for options for HIV prevention, we've actually bolded the different prevention options. And here at the bottom, this was important to us. We wanted people to give us feedback. Is this working for you? Does this need to be simplified further? Do you want more information? So once this was handed out, physicians actually had the opportunity to get in contact with us through a survey and let us know if it was working, helpful, what needed to be changed. And here is the back end of it again. So it's more of a flow chart. So as I mentioned before, the guidelines are in 4 categories. So a physician would typically follow one of these categories. If they're trying to figure out what prevention options, they go here in the green. If they're trying to figure out who's eligible for PrEP, they go here to the blue. But yeah, so this is more of a flow chart manner. It's basically just concise, more concise and condensed version of the front. I won't belabor you with all of this, but these were just some conversations that we had. But we basically had 2 to 3 months of deliberation back and forth, which just goes to show you that a lot of these things need to be really well thought out to make sure that they're actually receive uptake. And then some challenges that we had was how do we as students effectively communicate such complex information to family physicians? They're people who like detail and nuance, and we were trying to find a middle balance where we weren't getting too concise, but we were also retaining the relevant information that we needed. And so we leveraged the OHTN's network. We reached out to physicians and said, is this too simple? Is this retaining the information that you need? So we had a lot of deliberation through that. And then resource uptake was physicians are already so overburdened and their time is valuable. Are they going to have the time to use this little pamphlet? And so we did that through revising that flow chart several times. And I know to some of you, it might still seem like there's a lot of words on there, but trust me, there were more words before that. And then how are we plan on measuring uptake? As I previously mentioned, we're going to have electronic mailing lists, and we want to track downloads. Although this is not a perfect metric of how many people are using the tool, it's something. And when it comes to online deliverables, it's a little bit hard. So we wanted to look at website analytics, email read receipts, and downloads. And then, as I previously also mentioned, was the conferences. We wanted to see how many people were referring back to our QR code, giving us feedback and how this dissemination was coming about. And so all of these strategies are still their theories at the moment, and they will be piloted at the initial conference that we disseminate the flyers at, to assess their effectiveness. And so that was a lot. And so I want to bring it back to the big picture here. We had guidelines and we wanted to connect family physicians and Ontarians with HIV care. And so the little puzzle piece that this tool serves is that we want to support and empower family physicians in being able to communicate those guidelines to patients that come in. And so that is the end of my presentation. I've also left my email and LinkedIn should anyone want to connect or even want to leverage this tool. We've actually been contacted by, I think it was someone working with the Ontario HIV Treatment Network, subsequently like mirror in Saskatchewan. And so they wanted to reach out and see if we could adapt this to something that they could use as well. So if that's something that you're interested in or would like to connect and just talk about, I would love to do that. But yes, thank you for your time, everyone.
Great. Thank you so much, Fatima. Thank you, everybody. Those presentations were great. Great examples of KT U3. So now let's get into what is even more exciting is the Q&A section. So I can already see people are starting to ask some questions. I'm not sure if you three can also see the Q&A window. So I encourage anyone who's got questions either for all of our speakers or for one in particular, please put those into the Q&A window. And then if somebody has asked a question that you agree, yes, I really want them to answer that question, you can give it a thumbs up, which will, I think, upvote it and it moves it to the top of the list. So I'm gonna read through these and we'll go from there. So this first question is coming from Susan. It's a question for Vayshali. So she says, great presentation on a very important topic. Can you comment on what is known about unintended consequences of risk communications? So what do we know about the effects of poor risk communication? And can we actually cause people to discount risk? How can we guard against this? So 4 questions in one there. Take a stab, Vayshali.
All right. Thanks, Susan, for your question. So for the first question, can you comment on what is known about unintended consequences of risk communications? So that's kind of the thing, and I think a lot of it is like trial and error, and that's an important part of development of risk communications in the sense where you can develop one based on best practices, but it's kind of you learn from it as you go. So once you disseminate it, you really need to be collecting feedback to keep kind of like continue optimizing that product. Some unintended consequences. I haven't done this in my own research just yet because we've just kind of wrapped up. But I would think some people, like I had mentioned in my presentation, WellFact, sorry, presents numerical information about the number of people involved in outbreaks And we saw that some people would use this to kind of say, oh, well, not that many people got sick from this. And so while that's true, and a part of this communication is kind of to reduce fear around it, it's still a risk. So I really think the unintended consequences of risk communication is kind of around how people are perceiving these communications. I don't know if that exactly answers the first question. Um, and so, what do we know about the effects of poor risk communication? So, kind of that, it kind of goes two ways. It either has a positive behavior change. People are taking the risk communication, evaluating it, and making healthy decisions. And then, kind of the opposite, where it kind of gets dismissed, and people can either just dismiss it and not do anything about it, or can harm themselves further. And so then can we actually cause people to discount risk? I don't know if it's so much um, the risk communication itself that discounts risk, at least not from the government. Obviously, there's a lot of dis and misinformation, and a lot of that is to discount the risk. And people do believe it. And I feel like it's kind of the onus is on both the person, the organization to kind of promote health literacy so that individuals know um, how to interpret sources and where to get information from so that it's not mis and disinformation. And then how can we guard against this? Oh, kind of answered that. I think kind of like boosting health literacy is a big key part of this so that people are aware of where they can go for information and high quality sources. Yeah.
Perfect. Thank you so much for answering that. All right, the next question we have here is directed at Angel, but I will, after Angel answers, I'll open it up if Vayshali and Fatima have anything they wanted to add as well. So this is also from Susan. She says, thanks for your presentation, such an interesting approach. From your experience with and learning from EarthHug, what advice would you have for academics interested in KT of their research? So what are some of the takeaways that would have broad implications for KT?
That's such a good question. Thank you for asking it. A few things come to mind, but yes, I'd love to hear both of your responses as well. The first is, I think stretching when we think about like our audience or our partners for KT, I think stretching that much further than like, I think the typical kind of groups of audiences that we direct KT to and research. Like for example, like theater advocates was one group that like we did not approach or like think would come. And then that conversation between the advocates and like the researchers and a couple of policy folks were really, really interesting and so rich. And so I think just stretching in our imaginations, like who are the people working on the ground or who have these like kind of tertiary connections to the topics that we're working on. I think another big one was maybe space for emotional connection, which I think doesn't always happen in like one-way directed KT approaches, especially. But even in gatherings, like yeah, centering in ethics of care and love are not typically words that we use as much in research, but it takes it, I think, really far from what I've seen with like really creating the space for these raw conversations to happen in like challenging or enhancing research findings. Yeah, maybe I'll leave it there. I have a couple other ideas, but I want to hear what Vayshali and Fatima have.
Thank you, Angel. Fatima or Vayshali, would you like to tackle that one as well?
So sorry, I was looking at the other questions. Could you please remind me of what the question
No
was?
worries. It's this one here. It's what advice would you have for academics interested in KT of their research? So thinking about what are some of the takeaways that would have broad implications for KT?
100%. I think so. This was actually my first project doing some sort of knowledge translation. I was always someone who was on the back end of here are the numbers, here's the data. I hope it makes sense to people. But I think the biggest takeaway that I had was putting myself in the shoes of my target audience. So seeing what are they looking for, what is the purpose, and what would they want to take away most. So in my case, was family physicians was they want to know they want to know the guidelines in the quickest possible way. So switching perspective and putting yourself in the shoes of your target audience, I think was the biggest game changer for me. Oftentimes we get stuck in academic jargon and scientific jargon, and sometimes it's like, okay, well, if I'm let's say you're doing something that's targeted towards teenagers. If I'm a teenager and I don't have this scientific background, how would this make sense to me? So I think that was the biggest takeaway that I had. Um, I don't know if that fully answers the question, but I think that's definitely something that I took away was putting yourself in the perspective of your target audience, and then from there things just quite literally they fall into place a little easier.
Working backwards from who's your target audience and how can I
100%.
help the academics get there? Yeah,
100%.
wonderful. Vayshali, did you have anything that you wanted to add to this one?
Yeah, kind of just to echo like Fatima and Angel, I agree with everything they kind of said. I think one thing for me, the big piece was a collaboration in advance. So FAC kind of did their own investigation and then they wanted to outsource the rest of it so that it remained unbiased. And so I think like that was a very key collaboration from the outset of the project and it's kind of forgotten about. You can't just kind of do the research work and then try to uh, gear it towards your audience. I don't think they would appreciate a report of our research findings had we had not pre-established that relationship in advance. So that's kind of my one thing, I think.
Perfect. Thank you. All right, this next one is for Fatima. It's coming from Megan. And she says, what has been the general sentiment or feedback from physicians in their survey and with the emailing list? Did any major changes come after consultation with them?
Great question. So I will preface because the flyers have not been distributed yet. The only feedback that I can speak to is what we had during the process of creating it. And so the main feedback was physicians really like flowcharts. They like flowcharts. They like the ease of, okay, I need to go from point A to B. And so they really liked flowcharts. And that was something that we wanted to incorporate. And it was something that Diana also harped on. So again, she's the senior lead of education at the OHTN. So from her personal experience, she said, when we have workshops with physicians, they really always tell us they love things that are in a flyer dual format and they love things that are flowcharts. And so we took previous feedback and we incorporated and implemented it in the development of this flyer. And so we're looking forward to seeing. It would be interesting to see perhaps maybe if the sentiment or feedback is different. Perhaps they don't like the flow chart when it comes to guidelines. We're unsure, but we took the previous feedback and we hope that it results in higher uptake. But I can update you, Megan, with whatever feedback we do get.
Thanks, Fatima. And I think that this next one might be related. Sarah Ann is asking, will the guideline chart be translated in French?
That's such a great question. I would have to get in touch with Diana, but if Sarah, if you don't mind sharing your content, you can send it to me directly and I can email you back if once I have an answer from Diana. But I think she's in the process of finalizing and I'm sure there should be a translation in French, but I can get in touch with you once that's available.
Great, thank you. All right, so this next question is for everyone. And it's a question I had as well, Alana. Fatima, you had mentioned in yours presentation about roadblocks and some of your mitigation strategies for overcoming those roadblocks. And then you mentioned too, when you're talking about your timeline, that how important it was to plan in advance and to understand what's coming. I'm wondering, and Alana's wondering too, if the three of you could speak to some of the challenges you experienced and maybe some of the unexpected challenges. So you can plan for them, you can have these expected roadblocks and how you're going to mitigate them. But can you all speak to some of the maybe unexpected challenges that you experienced when you were carrying out your projects? And Alana adds, is there anything that you would do differently? So maybe I'll ask Angel if you wanted to jump in first. If you don't mind me putting you on the spot, of course.
Yeah, no, that's okay. It's a really good question. I think we had so many challenges that don't know where to start. I think something that I personally found really challenging was trying to get across the essence of what EarthHack is and like the feeling that it evokes when people are in the sessions. Like we have these really good quotes that people say, or like people will reach out and be like, wow, that like really felt I felt connected in a way I hadn't before, but I have a hard time kind of tuning into like explaining the event for some reason. I think when it has these, I don't know, we're trying to do different things and do things differently. And yeah, I think that was a really big challenge. And also just reaching people. Like when you do a global event, I feel this like there's so many people missed who have so many powerful examples and things to say in these spaces. And so like knowing how to reach the people who want to be here and who should be here. And that's been hard. And we kind of go from like who we know doing good work in the space and then kind of like snowballing from there. But I just know that we're missing so many people. And so that's something that I find really challenging with our KT.
Thanks for sharing, Angel. Vayshali, did you want to provide any challenges that you experienced? And then, is there something that you would have done differently?
Yeah, that's a really good question. I feel like there's always a kind of a challenge, especially most of them being kind of unexpected. Research never really goes as planned. Uh, I think one of the biggest challenges with mine was kind of achieving a representative Canadian sample was difficult. So for our survey, we did successfully apply for a grant, which was amazing. And so we actually applied sex, gender, income, and geographical location for our survey. So we got a representative Canadian survey that way. But when it kind of came to the focus groups, it was really, really difficult, especially because our incentive like wasn't quite high enough, I think. That was a major reason for participant dropout. And so our focus group's demographic was quite different than our survey demographic, which kind of made it harder to triangulate research findings with qualitative studies. And so something I would do differently, I think obviously our timelines were a bit tight because it was a research project that needs to kind of get done for around this time. But I think anticipating that the incentive is a bit low, kind of making sure that we're applying to grants in advance so that we have enough incentive to provide the participants and ensure that we have an achievable sample size that's kind of more representative. Yeah.
Great. Thanks, Vayshali. Fatima, did you have some other challenges you wanted to chat about?
Honestly, I think our project it was more in a vacuum with the sense of we were doing stuff in the classroom and we would discuss with our point of contact. Nothing that I can speak to directly. Perhaps it was challenging to, yeah, I think it was having enough background to speak on HIV, which is such a complex topic, and being able to put something together that made sense to physicians and wasn't too rudimentary. But I think that's something that was difficult.
Great, thank you. All right, this next question is for Angel. It's from Sophia. So she says, what kind of promotion or marketing did you do for the first summit? And do you have a specific evaluation plan in place to assess the reception of each subsequent years of the summit?
I love this question. Thank you. So for the very first summit, I didn't think we thought it would really work, so we didn't extend it as much as we have with the other two. But we really sent it to kind of people that we knew around the world who maybe would be interested, and then asked them to send it to everyone that they thought would be interested. And we actually had a lot of registrants that way. And honestly, I think a lot of academics who have a lot of say and a huge community were really supportive of this being like a student-led thing. And so I was really appreciative of all of the like researchers and established like professionals who were really supportive of this. And so that helped. And then for evaluation, we've been doing it unfunded for 4 years, our team, and we've wanted to do this like really rigorous evaluation, and we've made the plan, and we just all do it on the side of our PhDs and other degrees. It's like our passion project, and so we've been focusing more on like building the community and doing like local grounded kind of earth hug events that lead to the bigger ones, and so it's kind of fallen away, but it's something that I really, really, really want to do and will hopefully do really soon. But the plan is written out. We just haven't had the resources to do it quite yet.
Some could say that's a challenge. Absolutely.
Yeah, that's true.
Amazing. Thanks, Angel. All right, Vayshali, I'm going to ask you two questions. They are related. So the first one comes from Lara, and she says, excellent presentation. I echo that. She adds any insights into why there were differences in risk perception from the survey results as compared to focus group participants.
Yeah, that's a really good question. I think I kind of alluded to it in my last response. Um, while we had recruited our focus group participants from the same pool of survey respondents, the sample size was much smaller. So I think I mentioned our survey had 2,300 respondents. And this was not equally distributed, but we applied the 2021 census data. So it was representative of income, age, sex, and geography. Whereas the focus groups, we kind of applied light representation to it, but it was much harder because we didn't have as much uptake with it. And so there were some demographic differences. And actually, with the survey, I did perform regression analyses on it. And we did find that several socio-demographic factors influences things like awareness, understanding, behavior change, which in turn is risk perception. Um, and so I think it was kind of differences in demographics, and that's kind of why we saw that. I also think there's kind of reporting bias. So I think like social desirability bias, people will often say things that are kind of with the social norm. No one wants to say that, oh yeah, I wouldn't use this to help my illness later. So I think that there's a bit of that as well.
Great. And I said it was going to be a two-part question, but I think Brooke's question is basically very similar. So I'm going to say, Brooke, if I've misinterpreted your question, please add to it. But I think that Vayshali just covered it there when she was talking about the difference. Why was there this discrepancy between the survey and the focus group? Great, thanks so much. So for Fatima, I've got a two-parter question for you as well. So Jillian asks, was any research done as to the best way to encourage guideline acceptance or use by family physicians? So for example, why a print educational material versus something like in-person outreach visits?
Definitely. So a lot of the research has already been done by Diana, who is more frequently in touch with family physicians. And so, a great thing that the Ontario HIV Treatment Network does is that they actually offer workshops for physicians to come in, and it's held through the Temporary Department of Medicine. And so, they actually host workshops, and I'm sure Diana's presently hosting workshops with family physicians discussing the guidelines. And so what we wanted to do was we wanted to give physicians something that they could take with them to their office afterwards, was after they leave the session and they've gotten well versed on the guidelines, we wanted them to have something tangible that they could put, maybe stick up on their office or have as a ready use. So I think so it's not that it was either or, it wasn't either flyers or workshops. We'd use them in conjunction most often. And same thing with conferences. A lot of the times, guidelines will be discussed at these conferences, and because we want to really hone in that message, we want to give them something that they can walk away with. So I hope that answers your question.
And she added to, I'm sorry, I can't remember if you said this, but were any family doctors, did they provide input during the development process as to what they would prefer?
Yes, so the feedback, as I previously mentioned, Diana had already has a little repository of everything that she's already gotten from family physicians of this works, this doesn't. So we used that as our baseline measure to see where to start. So that was our starting point. We knew that they liked flowcharts and we knew that they liked flyers. So that was our starting point. And of course, the flyer is up to revision as we get feedback, and that feedback will come once it's been disseminated at conferences and at the workshops that I've just mentioned.
Great. All right, there's two more questions currently in the Q&A. Fatima, they're both for you. So if anybody has any other questions, I welcome you to put them in. So this first one's coming from Joel, and you've touched on some of this already. But Joel says, first, great presentations, Vayshali, Angel, and Fatima. Wonderful to hear the diverse KT approaches that you have incorporated in your areas of research. And I would echo that. What's been great about this webinar, in my opinion, has been how diverse your approaches have been and how diverse your topics have been. It's been really interesting. So Joel says that he says Fatima's work is similar to his own focus in tuberculosis, and he has two main questions. One, given that your target audience were physicians, were they engaged in the development of the tool? And you've just answered this, but if so, at what capacity and how was that? How were they integrated? And then secondly, have you considered doing a follow-up survey or qualitative study to identify how the tool is being utilized and what were the barriers and facilitators in adapting?
Most definitely. So something comes to mind again for that first question that you had just asked. We do want to engage them with our mailing list. So OHTN has a large network of family physicians. And so I think that would also be, like you said, a great point was we can engage them there as well, correct? So we wanted to look at the website analytics and the downloads. So once we're sending a flyer out, are they receptive to it? Or is there another method? Do we want to hand out these flyers more in conjunction with workshops and conferences and they're being less taken up in email format? So they had already previously been engaged by Diana. Diana has a list of feedback, and I'm sure she's collecting more as we are running workshops with the guidelines. In terms of doing a follow-up survey and qualitative study, so the way that we wanted to cover that base was we added that QR code. And I know QR codes they don't always get the most uptake, but at the end of our flyer, we have a QR code for them to give us feedback. But I think that's a great point was maybe that's not capturing everyone who's having barriers and issues. So I think, as let me write this down to discuss. But yes, I think we might want to do some sort of another survey or qualitative study to see what the barriers might be. So I think that's a great suggestion, and the capacity that we've done it to is allow them the opportunity to use a QR code.
Amazing. Amazing. All right. And then Fatima, Susan has a question. Again, she says, thank you for sharing your work. And it's related to risk communication. So she says, is there any aspect of risk communication that we heard about from Vayshali that is relevant for physicians as they are thinking about prescribing PrEP? So do physicians and their patients need more support specifically on assessing risk for HIV exposure that might lead to a decision to prescribe?
So definitely, I don't think I can speak on the on the end of a physician, but I would assume that in order to assess risk exposure, that building that rapport with your patient is probably so important. So in order to get an accurate risk assessment, there are such nuanced like populations that are marginalized as well. So let's say perhaps you're a member of the LGBTQ community, but then you also have intersectionality with being South Asian, and then that plays into your risk exposure. So all of these different identities that people are coming to, um, the family doctor with, I definitely think that's a conversation of how do we get more nuanced risk exposure assessment. And so unfortunately, presently, I think that the guidelines want to capture a breadth of people, so they're more I would say didactic in how they're constructed, but there is definitely of how does someone's risk compound if they their identity intersects with X, Y, and Z. So that's definitely something to consider. And I think the way that I definitely don't think a flyer could could by any means support a family physician in doing all of that. But I think maybe a workshop might be a good starting point.
Great. Thanks, Fatima. Nora, I think that maybe this question is for Fatima. She asks, were resources produced, created in plain language? Why or why not?
So, given that our target audience were family physicians, and those were the main uptakers of our resource, they weren't created in plain language per se, but the Ontario HIV Treatment Network has plenty of resources should you want to visit their website that are for patients or people who are just curious about maybe assessing their own risk. But no, they presently have not been created in plain language, given that our target audience are physicians, and they probably want a little bit more nuance when prescribing and assessing risk exposure.
Great, great. All right, those are all the questions that are currently in the Q&A. Again, I welcome, Nora just says thank you. So I'll give people a moment if they want to add some more. I have one, it could be a final question for all three of you. What I loved also about your presentations was that you all spoke about your collaborators, you all spoke about your mentors, how you got to where you are, who's kind of helped you along the way and what you've learned from them. But now I want to give you the opportunity to be the mentor. And my question is, what advice do you have for other students who are either entering into the field of KT or just really starting to dip into what is knowledge translation and how can I apply this in my own projects? So who would like to start? Fatima, maybe take a break. You need to catch your breath. Vayshali, did you want to start?
Sorry, I was just reading the one question as it popped up. But I think you were just asking like what would I tell a student who's just starting out with KT stuff?
Yeah.
That's tough. I feel like for me, it was kind of like a lot of learning on the go from like my mentors. Um, and I didn't really have like a good like jump off point in the sense. Um, I think first and foremost is familiarizing yourself with what KT is. I feel like a lot of people think they know what it is, especially in academia when people are like, oh yeah, like I published this research paper in a journal or something like that. But that's not quite exactly what KT is about. So maybe I think a starting point is truly understanding what it means, I guess. Yeah.
Amazing. Thanks, Vayshali. Angel, what advice would you give to students dabbling into knowledge translation?
I think one is like knowledge translations are really great opportunity to bring your passions in as well. Like I have a coworker and friend who does aerial and might bring that into her research KT, or like poetry. There's lots of like poem-based analysis you can do, or like music. So I think that, and then also like finding your community of people who will support you in like having the big ideas and trying to find ways to make it work and getting excited about translating your knowledge.
Thanks, Angel. Fatima.
Definitely. So I guess I think I would start with understanding your objectives of your research first. You need to understand why you're doing the research that you're doing and what is the purpose and who are you trying to impact. And so I have done that several times now. I think after this experience, I do that now with a lot of my projects of what is the story I'm trying to tell? Who am I trying to relay this information to? And what is the purpose of it? And I think revisiting the objectives throughout the course of your research or your like anything that you're doing, it will indefinitely help you with knowledge translation because knowledge translation is just that. It's bridging that gap between like research and academia and then seeing it like manifest into whether that be policy or actionable steps. And so knowledge translation is that middle part. And in order to, I think, leverage it and do it well, you need to understand why you're doing it in the first place. So who is your target audience? What is the purpose? Who am I trying to impact? But that was the biggest takeaway that I had through this process. And I would, yeah, that's the big picture. Just know why you're doing the research and understand your objectives well. And that will most definitely help you when it comes to knowledge translation.
Amazing. Thank you all for that great advice. Vayshali, are you answering this question in the Q&A via typing, or did you want to answer it live?
Oh, did you see that I was typing it?
I can see that. So the question for anyone else who isn't reading it is, how was representativity of language included and or excluded in your evaluation?
Yeah, so that's a great question. So since we did do work with the Public Health Agency of Canada, the survey was disseminated in both official languages. So there was an option for English and French, and the French was translated by FAC. So in terms of official languages, yes. And then in terms of the quotas, we were kind of limited to what we could afford. So we couldn't really do it representative of language. But we did have an option for another language, and there was like I wouldn't say a substantial amount of people who had reported that English or French was not their first language, but enough to do survey regression analyses on it to show that people whose first language was neither official language did have a lower awareness, understanding, and use. So it's definitely something to keep in mind when creating risk communications and making sure that it is translated in appropriate languages for Canadians.
Great, thank you for that. All right. Last chance if anyone would like to ask some questions. I'm going to again leave this Q&A open for now. Thank you, all three of you, for first, your great presentations, and then secondly, this really informative Q&A session. It was really, really interesting to hear your different perspectives on, I think we often say knowledge translation as a single thing, but as you've shown us, it's so diverse. There's so many aspects to it. And I think that your presentations and your answers to the questions really, really highlighted that. So like I said, I'll leave the Q&A open in case anybody has any last questions. And of course, if anybody ever has any questions for each of you individually, I know you've all shared your contact information throughout. And at the end, I'll also share the contact information for NCCMT so people can reach out if they have any last questions later. So I'll finish up today's webinar then with a couple of resource slides here. So the first one is, if you want to learn more, so come and visit our website. When we did our poll at the beginning, we found that it was a 50-50 split basically of people who've used our resources and those who haven't. So for those who haven't, come check us out. Our website is nccmt.ca. And you'll see at the top of our page, we've got top of our site, we have different tabs. The one that might be of most interest to you here is our training tab. And this is where you can find resources like we have a new page coming soon that has all of our events and webinars on it. You can also come here to complete different learning needs assessments to see, what is it in evidence-informed decision-making in public health that I want to learn more about. You can try out some of our online learning modules, watch some of our videos, and you can drop into what we offer on Thursdays at lunchtime, Eastern time, we call them our knowledge broker office hours. So this is an opportunity for you to come, and if you've got a question about evidence-informed decision-making in public health, about knowledge translation, you get a chance to come and chat with myself and my colleague, Emily Clark, a fellow knowledge broker at NCCMT, and we just talk about what your questions are and see if we can help in some way. So check out our website, check out our resources. And for any students on the call, these awards will be offered again next year. So please stay tuned, come back to our website and see if you want to apply in 2026. We'll finish with another poll. So you should see this pop up in a moment. And this is just a quick workshop evaluation poll. So basically, what was your impression? Did we meet your needs and expectations? All of your answers are anonymous. And again, we use this evaluation data to inform and improve all of our offerings, so improve our future webinars and our future workshops. So I'll give you a moment to fill that in. Thank you, everyone who has participated. And while those answers are coming in, I'll ask one more time if there are any final questions or any final comments from anyone, from the audience, from our panelists. Again, thank you so much for your participation. It's been a really, really interesting day. It's been a hot day for many of us, so I hope everyone was able to stay cool during this conversation. Here is, if you scan this QR code, you'll get to our website. And you'll see there as well an email address, nccmt@mcmaster.ca. You can contact us there should you want a copy of the slides or should you wish to reach out to either myself or any of today's presenters with any follow-up. And Krishan has just posted all of these links in the chat as well. Okay, great. Well, again, thank you, everyone. I think we'll end it there. Enjoy the rest of your day, and we'll see you all again soon. Thank you.